Prostatitis is defined as microscopic or macroscopic inflammation of the prostate gland and is one of the most common conditions affecting the prostate. According to the National Health Institute, 4 syndromes of prostatitis have been identified: acute bacterial prostatitis, chronic bacterial prostatitis, chronic prostatitis and chronic pelvic pain syndrome, and asymptomatic inflammatory prostatitis. Chronic prostatitis and chronic pelvic pain syndrome is the most common form of prostatitis and accounts for approximately 90% of cases. It typically occurs in the absence of a urinary tract infection. The etiology of this syndrome is multifactorial, with occult infections, autoimmune, psychological, and neuromuscular factors contributing. Chronic prostatitis and chronic pelvic pain syndrome is further divided into 2 types: inflammatory and non-inflammatory. Inflammatory type is characterized by the presence of white blood cells in the semen, expressed prostatic secretions, or voided bladder urine following prostatic massage. Non-inflammatory type doesn't contain white blood cells in above-mentioned fluids. This syndrome of prostatitis can have a negative impact on sperm quality and fertility. Acute bacterial prostatitis can be caused by ascending infection through the urethra, which could be a sexually transmitted infection or a urinary tract infection, or through direct extension or lymphatic spread from the rectum. Common causative organisms include Escherichia coli, Enterobacter, Pseudomonas, Enterococcus, Serratia, and Proteus. Mixed bacterial infection is uncommon in acute bacterial prostatitis. In a sexually active male, especially when younger than 35 years, Neisseria gonorrhea and Chlamydia trachomatis should also be considered. Additionally, indwelling urinary catheters and sclerotherapy for rectal prolapse increase the risk of acute bacterial prostatitis. Chronic bacterial prostatitis usually occurs due to a primary voiding dysfunction, which could be either structural or functional, that increases the risk of bacterial colonization. Escherichia coli accounts for about 75 to 80% of cases. Other organisms include Enterococcus, Pseudomonas, and Mycobacterium tuberculosis. Sexually transmitted organisms such as Chlamydia and Trichomonas vaginalis can also cause chronic bacterial prostatitis. In addition to bacterial species, certain viruses like HIV and CMV, fungi, protozoans, as well as inflammatory conditions can also cause chronic prostatitis. Asymptomatic inflammatory prostatitis is characterized by the presence of high white blood cell counts in the ejaculate, with elevated prostate-specific antigen, or PSA, in the absence of an infection or genitourinary symptoms. This condition is commonly associated with benign prostatic hyperplasia and is often detected incidentally during workups for infertility. Clinical presentation of prostatitis may vary according to the subtype. Patients with acute bacterial prostatitis typically present with fever and chills, malaise, joint and muscle pain, perineal or prostatic pain, lower abdominal and back pain, spontaneous urethral and obstructive urinary symptoms such as dysuria, frequency, urgency, nocturia, poor urine stream, and incomplete voiding. On examination, these patients will have suprapubic abdominal tenderness along with an enlarged, tender bladder due to urinary retention. On digital rectal examination, tender, nodular, warm, and boggy prostate gland may be palpable. However, sometimes the digital rectal examination can be completely normal. In chronic bacterial prostatitis, the patient has intermittent dysuria, obstructive urinary symptoms, and recurrent urinary tract infections. These patients have normal examination findings between acute episodes. Patients with chronic prostatitis and chronic pelvic pain syndrome typically present with pelvic pain and discomfort. Most common areas of pain include perineum, suprapubic region, rectum, urethra, testis, and scrotum. Obstructive urinary symptoms such as dysuria, frequency, and incomplete voiding may also be present. Some individuals may complain of erectile dysfunction and ejaculatory pain. About 25% of patients with this syndrome have coexistent inflammatory bowel disease. As the name suggests, asymptomatic inflammatory prostatitis does not produce any symptoms or signs. Prostatitis can lead to several complications, including the following: bladder outflow obstruction and urinary retention, abscess formation, especially in immunocompromised individuals, infertility, due to scarring of the urethra and ejaculatory ducts, recurrent cystitis, renal injury, and sepsis, especially in immunocompromised and postoperative patients, diabetes, and chronic renal failure. Prostatitis should be differentiated from urinary tract infections by functional urine studies and cytology of expressed prostatic secretions. In addition, urinalysis and urine cultures can help identify the causative organism. Trans-abdominal ultrasound scan can be used to assess the retained urine volume in cases of bladder outflow obstruction. Trans-rectal ultrasound scan can identify the characteristic features of prostatitis. Treatment of prostatitis depends on the type of syndrome. In acute bacterial prostatitis, if the patient is very ill, unable to tolerate oral intake, unable to urinate voluntarily, and if there is evidence of sepsis, admission to the hospital is mandatory. They should be given intravenous antibiotics such as fluoroquinolones, aminoglycosides, penicillin derivatives, or third-generation cephalosporins. Since urinary retention can complicate acute infection, suprapubic catheterization may be required in such cases. Additional supportive measures include temperature control with antipyretics, analgesics, hydration, and stool softeners. In cases of prostate abscesses, the abscess should be drained either transrectally or transperineally. Chronic bacterial prostatitis and chronic prostatitis with chronic pelvic pain syndrome typically require 4 to 6 weeks of antibiotic therapy.